Thanks so much. Thanks for joining us this afternoon. So today I'm going to, in terms of learning objectives, describe the expanded scope of care for pharmacists and how it relates to substance use care. Describe how the expanded scope of practice for pharmacists, and focusing on BC right now, supports clients' journeys throughout the systems of substance use care. Compare, because it is confusing sometimes, what is an emergency supply versus a pharmacist prescription extension or renewal. Those are the same wording that we use. And also finally discuss client-centered approaches to support the retention of care, which is really important in this space. So really, a majority of people with substance use disorders are not engaged in care in BC. So you're looking at about 114,000 with OUD, and less than 35,000 receive OAT, or opiate agonist therapy. So as you are all aware, British Columbia is currently really facing unprecedented healthcare system challenges characterized by large-scale clinician burnout that we've experienced, and nearly about 2 million residents waitlisted for access, really access to a regular family physician or even a specialist care. So clients are overwhelming walk-in clinics, emergency rooms that we've read about, looking at refilling prescriptions. And of course, we have an aging population in terms of the healthcare workforce, and also lots of retirements over time. So access to treatment and services are so important, and they are the standard of care for substance use disorders. In terms of substance use disorder, it's really limited right now. So in terms of pharmacists, pharmacists can be vital to addressing some of these care access and retention gaps, and you've seen this in the last year or so. So historically, pharmacists has been successfully engaged to address public health access care and gaps. So our role has gradually moved from beyond dispensing to immunization, which you have seen, clinical management of a lot of the chronic diseases, diagnosis and management of minor ailments, which was just last year, and other activities to support public health. So during COVID-19, you could see that pharmacists demonstrated aptitude for increased responsibility. So people with OED struggled with access to OAT, and to address this, Health Canada actually issued a short-term subsection 51 exemption, 56 exemption, authorizing pharmacists to manage some of the controlled substances, which I'll talk about a bit later on. And a little bit later on, I'll talk about the extensions and transferring prescriptions as well. And throughout the pandemic, pharmacists were able to provide really a continuity of care to clients with OUD, who would have had otherwise been unable to access care. In BC, this is a little map of British Columbia. There's about, when you look at registration, there's about 7,000 licensed pharmacists in practice in British Columbia, and about more than half of them, 4,200, a little bit more than that, working in community settings scattered throughout British Columbia. So each year, there's usually about 1,500 new pharmacists licensed in BC, and many of them, a majority of them, are community pharmacists. So for example, in the 2021 to 22 period, about 1,500 pharmacists were licensed in BC, and over 1,400 of them were community pharmacists. So this is a really large expanding care resource. So the map on the left, on the right, actually shows a distribution of pharmacists in BC, and you can see that there, like any other health provider, there needs to be more pharmacists in rural and remote areas, particularly in the north. But it also demonstrates that this is really an added workforce to enhance substance use care. And you can see how people in rural remote areas, you can see, the broad range of British Columbia, can really experience a lot of travel burdens related to substance use care. So enabling pharmacists to offer those prescription extensions the last little while, and emergency supplies, which in BC we've always had, is really a step towards reducing barrier and access to care. So I'll go through a little bit in the next slide, just some of the timing, so that you're aware of what's happening in the pharmacy space. And like the RNs, RPNs, there's a lot of scope changes that has happened. So specifically to British Columbia, the Ministry of Health actually started expanding the pharmacist scope of practice in around the fall of 2022. This is done in collaboration with the regulatory colleges and other partners. So essentially, the first little bit in October was the ability to allow pharmacists to adapt or renew prescriptions for a wider range of medications. It used to be that there was a limited range, but this is really an expansion of many types of medications that pharmacists can adapt and renew within practice. And that was launched in October 2022. Later on, in June 2023, just last year, you saw, similar to many other provinces, there was the ability for pharmacists to assess and prescribe for 21 minor ailments, freeing up other clinicians' time to look at other items, and also the ability to look at contraception. And that was, again, in the summer of last year, early summer. The third thing that is really relevant to substance use care is the ability to expand the scope to administer a wider range of drugs via injection. There is an injection fee that was added to support the administration at a community level. So this really actually includes extended release formulation of buprenorphine that's out there, and many of the antipsychotic medications that we couldn't have done in the past. So really these three things help expand access to care in a setting that patients might attend to. So it's really a key role when you're looking at pharmacists, being able to provide certain medications for individuals that can't access a primary care provider or a clinic. There's increased access to care, there's increased care continuity, and more integrated care. And you see this with some of our other colleagues where there's a lot of back and forth discussions about clients, or discussions even about processes and scope of care. The next slide demonstrates really, this is from a Canadian Pharmacists Association website. You can look at it, you can Google it, and it's just looking across Canada what's changed over time. And it used to be a lot of reds way back when, and over time, as regulations change, as scope practice changed over time, these became tick marks. And you can see within British Columbia, we discuss a few things about, prescriptive authority, such as for minor ailments, there's a check mark, smoking cessation and emergency, we've always had that. Alberta, a province all over, has a little bit more scope because legislation does differ across the different provinces and territories. So these are some of the things that you can look at if you're curious about what your pharmacist colleagues can do over time. I'm going to go through really a little slower in explaining the differences between emergency supply and extensions or renewals. In our BC regulations and in our college, there's something called a Professional Practice Policy 31. And what it talks about is we've always been allowed, or pharmacists have been allowed, to provide an emergency supply of medications to clients without a valid prescription for a period of time. But we can't just do it on a whim, right? We still have to look at collateral information. So that might be something that we discuss with our prescriber colleagues. It could be something we discuss with our clients in front of us, because we have to complete the assessment and use our judgment to document appropriately. So I have to, for example, I have to have the knowledge of the condition. Have information about the health status. I have to ask the client, is it okay if I offer an emergency? And I have to document everything. And of course, it's under my license, and notify other healthcare providers within the team, just to update everybody, because that's part of the care process. And then, of course, have the discussion with the client a bit more on next steps. Usually an emergency supply prior to some of the new scope changes was provided when a client hasn't been able to get to an appointment, or maybe the prescription ended on a certain day, or perhaps their pharmacy was closed. So I would go on the PharmNet system to assess this to provide an emergency supply. And usually I won't necessarily have the at that time. I'll actually go to the next slide to explain a little bit more about this. So, for example, let's say the benefit is, let's say I was talking about a client's prescription expires on a Saturday, couldn't see a prescriber. I use an emergency supply to provide a bridge. So that's my ability to do that. And I can use collateral information, like I said. And really, we're looking at decreasing treatment or interruption. We're looking at reducing related harms, including many of the withdrawal and regulated drug use, drug poisoning, and really lowering the burden on other systems due to lowering the risk of drug-related harms. So when I'm looking at providing an emergency dispense or not, these are the things that go through my head and some of my other colleagues' minds as well. And it takes a lot of comfort because I have to know the condition quite well. And sometimes, some of my other colleagues that don't have as much experience, they reach out and they ask certain questions as well. So that's an emergency supply. In another situation right now with this new tool, we can actually extend a prescription or renewal a prescription. Those are very similar wording. So under this practice policy 58, we can actually prescribe a renewal or extend a renewal, provided I have the original. So if I have the original prescription at my location, I can actually renew according to the prescription based on the timing. So let's say the previous prescription had timing of about a week. I can renew up to a week. When I assess it, I can renew a bit less when I assess it if that client was going to the clinic at a certain time of day or they're going in a few days. So that's the difference that you can see now in terms of renewal versus emergency. In the renewal process, I have to have the original. If I don't have the original, the pharmacist may do an emergency supply. So benefits, again, is a lot of that stability. They may not have to see that prescriber immediately if something happens. We can provide the emergency or extension without that valid prescription for a period of time. And it's always good, I always say to even our team here, like just let the clinicians know, the prescriber team know, so that there is even improved collaboration and continuity for the clients, the flexibility. And some of that demand, especially after a long weekend, if things aren't caught up, it can help the system a little bit more to help the client reach and obtain therapy. And so more ability to look at the client as a whole. So this is an example of a 28-day script. So let's say, for example, I'll walk you through, you're very familiar with this. The start date is January the 6th, 2023 until February the 2nd, 2023, 28-day script. This says once a day, take home doses, no witness. Should a person come back on the 3rd, let's say something happened, didn't make it to the appointment because maybe there was a shortage even at the clinic. Maybe there were cancellations, appointments can move around. Then from my end, if I have the original prescription, what I can do is actually provide an extension. I can extend to a month if I'm comfortable, depending on stability, depending on when the next appointment is, I can extend a bit less. If a client walks in and they filled this prescription somewhere else, I might call, for example, Jody up, maybe it got filled somewhere else. To have that collateral information to see whether or not there was an outstanding script, or I'll provide an emergency until the person gets back home to their home pharmacy, as an example. So those are the differences when I look at everything in terms of assessment. So next slide here. This is an example again. So the first one was buprenorphine naloxone. This one is methadone. So methadone at 100 milligrams once a day by mouth. This is a 28 script, looks fairly stable in terms of assessing this script. Again, I use my same assessment process where I'm talking to the client, any collateral information. Yeah, on PharmD itself, if the clinicians or any other care team or even the patients, if they see their PharmD record, if I gave an emergency supply in front of your directions, it'll say emergency. And then if not, it'll say, if not, what it'll say is adapted. So those are the difference if you're a clinician team looking at PharmD, or even the client themselves looking at PharmD. But again, it's that assessment of everything, and then hopefully the client can address where they're going next in terms of either the appointment or whether or not they are going back to their home pharmacy. So next slide, please. So this is a shorter prescription. So this is a week's prescription, oral slow release oral morphine, 200 milligrams once a day by mouth. It may or may not be a new start. You'll have to talk to your client about it, and also assessment in terms of the prescription, and also in terms of the care team. Sorry, it's a little bit noisy here. I'm just in the clinic setting right now. And individuals, as a reminder, it can be swallowed whole, and I would do the same assessment. This is a script like any other script. It is an opioid script, the same thing. I can extend up to a week because that's how it is, or provide emergency. If after a week, let's say the client couldn't get to the clinic, or the clinic was a little bit busy, I can always talk to the clinic and provide some emergencies depending on what's happening with individuals and also within their clinic team. So next slide. I'll go through a little bit. I'm just going to switch gears a little bit in terms of talking about minor ailments and contraceptives. So as of June 2023, almost a year ago, we can actually, as pharmacists, assess and prescribe 21 minor ailments. And we actually have to complete certain education and just a relook at some of the stuff we already learned in the past. Just going to go through how this can transition in terms of meeting clients at their needs. So new tool really facilitates integrated care, helps to bridge healthcare plans and healthcare in the system when a client shows up for items. So regardless whether or not they have access to primary care, people can access a pharmacy directly to look at their minor ailments. And in terms of impact, when you look at yourselves even going in a pharmacy, or other individuals going into pharmacy, sometimes other things happen that you need care for, not just, for example, substance use disorder, not just other medications. So it's easier access to care for some of the minor ailments that for managing some of the conditions and comorbidities. So next slide. So some examples, and you can look through, it does vary. It does totally vary province to province right now as we look across the different provinces, but there are similarities. So some examples that pharmacists can assess and prescribe, and I'll go through a few of these. Even now, a lot of individuals don't know this access to care yet. Conjunctivitis, pharmacists can prescribe certain ophthalmic drugs. Fungal infections. Sometimes a lot of our clients have other conditions, right? UTIs, for which pharmacists can prescribe some antibiotics, GI reflux, nicotine dependence, which is really important for being looked at in terms of some of the outcomes related to smoking. Musculoskeletal pain, there's ulcers, there's shingles. Usually it happens on a Friday. candidiasis, and also the full list is really listed, and you can look a little bit more about that to help support your clients wherever they are, and have the knowledge, or tell them also in terms of where certain access points are, depending on where you are in the province. So next slide, please. So the third thing I wanted to talk a little bit more about is administration of injections. And originally, way back in 2019, or no, 2009, sorry, lost a decade there, but 2009, really in British Columbia, injections expanded over time. And it was a basic injections starting off with the flu, and then eventually you saw a lot of the travel vaccinations, other vaccinations. You saw the COVID vaccinations the last few years. So we can actually now, in terms of pharmacists, provide basically intramuscular sub-Q injections in a wide range of sites. Knowledge, skills, and abilities is really important for the pharmacist clinician to really have a look at and assess their comfort level. And how it pertains to substance use care is the ability to finally now be able to afford out the extended release buprenorphine that we can give an injection to try and retain care too.
Hey Mona, sorry,
Yep.
just to pause. Thanks so much for an excellent presentation so far. Just looking at the time, just to let you know we've got about 4 minutes left before we'll have to go into the case.
Yeah, no problem. So that's not available there. So benefits, of course, with everything is the minor ailments and contraceptives, the administration of injections, and that's available for you to have a look at. So I wanted to go over just for a quick few moments is really client-centered care collaboration to tailor care. And this is essentially what we do as pharmacists, expanded scope, understood as a measure, right, to facilitate client-centered care in our healthcare system. And we go through our assessment process in our education is really looking at indication, effectiveness, safety, adherence, any unmet needs. So that's why sometimes when a client comes in, we have to ask a little bit more information in order to understand the whole complex system of the individual in front of us to try and support care. And really, the next slide is it's all about client-centered care. It's about meaningful partnerships, and we're doing this a lot more along with our other clinician colleagues. And um, it's the system's limited capacity is so important, and sometimes, unfortunately, there's stigma, judgment, and exclusion still that we're all trying to work on still in terms of having those meaningful partnerships, in terms of meeting the clients at their needs, and pharmacy settings is another place where people can reach out to access care. So next slide. So the same, consider the treatment goals, circumstances, preferences, and values. And I cannot stress so much is the collaborativeness of reaching out to everybody's care team. It's so important so that we understand the client's needs. Engage, empower, that's the next slide, as agents and experts in their own care. It's just a reframing and rephrasing of acknowledging and looking at that power imbalance that we used to have a lot more of way back when in terms of care dynamics. Key strategies, of course, the next slide is really the shared decision-making model, so important. Health and well-being, engaging the client, and our students are learning a lot more about that now in terms of their education and sharing information, and hopefully that changes a lot of things in the near future or forever, hopefully. You've seen this principle of care in terms of the next slide. So in closing, these are the fundamental principles of care, and you see this in our OUD guideline. All professionals actually providing care to people with substance use disorder must be familiar with these overarching principles of care, and you see this a little bit more in discussion within the OUD guidelines that some of us have already talked about in previous presentations. So I'll go to the last slide now. A summary is really expanded pharmacist scope enables pharmacists to enhance access and to integrated care. We can provide emergency supplies, extend some of the controlled drug prescriptions, including OAT, the 21 minor ailments and contraception within BC, administration of more medications, more types of medications. And we also have to look at our professional judgment and assessment as our collaborative colleagues and our clients on as part of the assessment process. And really focusing on the client-centered care to hopefully decrease a lot of the stigma and enhance retention. So these are some resources for you. There's a lot more. There's also administration course of Sublocade. If those individuals are interested out there, it's for everybody's use. So that's located there for you, and we'll provide more resources a bit later on too. And then the next slide. Some references there are for you. And of course, the addiction medicine clinician support line, really good number to call. That's the next line there. It's for pharmacists too, pharmacist colleagues and other clinician colleagues that would like to have a bounce back of ideas.